Okay. Good day, everyone. I'm Chelsea Khan. Hi, I'm a host officer attached to neurosurgery at Eric Williams, and today I'd like to enlighten you all a bit about craniopharyngiomas. So let's get started. So according to Mr. Harvey Cushing, aka the father of neurosurgery, craniopharyngiomas are the most formidable of intracranial tumors. They are slow-growing, extraaxial, epithelial, squamous, calcified, cystic tumors, which are classified by WHO as grade 1. They are actually benign, however, they behave malignant and are the most commonly located in the cellar/supracellar region. Due to their slow-growing, insidious onset and ambiguous symptoms, which actually occur due to the compression of normal pituitary tissue and optic chiasm, it tends to manifest as raised intracranial pressure, visual disturbances, headaches, and endocrine dysfunction, more specifically, hypothalamic pituitary dysfunction. Regarding the incidence, 0.2 to 2 new cases occur per million people per year worldwide, with 1.2% to 4% of all intracranial tumors and 56% of cellular chiasmatic tumors being craniopharyngiomas. There are 5 to 11% of brain tumors in children, with 80% being in the hypothalamic pituitary area. There's up to 80% survival rate for 30 years. However, there are multiple relapses and procedures in between. Craniopharyngiomas can occur at 5 to 14 years and 50 to 74 years and are most commonly male predominant. They are also seen more in African racial groups. Etiologically, there are two main subtypes, these being the adenomatous craniopharyngioma, or ACP type, and the papillary craniopharyngioma, with the mixed type being an honorary mention. In terms of development of these types, the pathways involved are the wingless WNT beta-catenin and the mitogen-activated protein kinase / extracellular signal regulated kinase, or MAPK-ERK. The WNT beta-catenin pathway persistent activation causes a cytoplasmic accumulation of the protein beta-catenin and its nuclear translocation, which then activates transcriptional factors of the T factor lymphoid-enhancing factor family, which in turn activates other genes that ultimately cause cell migration and proliferation. The WNT pathway has multiple phenotypic effects and so regulates other genes such as GSK3, which activates mTOR, RIKE, and SRC, to name a few. Retrospectively, an abnormal activation of the beta-catenin gene, CTNNB1, is mostly present in the ACP-type tumor, specifically in exon 3, which enhances the resistance of the protein to be degraded, thus resulting in activation of the WNT beta-catenin pathway. The pathway type is primarily seen in ACP as they show beta-catenin nuclear aggregation, and thus accumulation of the beta-catenin has been shown to be a diagnostic hallmark for this variant, especially since accumulation is linked with epithelial transformation. So regarding the embryonic development of the more common ACP subtype, it is best described by the embryonic theory. If we can look at the picture here, we can see there's an outpouching of the ectodermal roof of the stomodium, which is rat case pouch essentially. This extends cranially towards the floor of the diencephalon to later form the adenohypophysis. So while migrating cranially, the craniopharyngeal duct is formed, but later involutes. But sometimes subtotal involution occurs and remnants of the ectodermal cells are present, which can proliferate around the extension of the craniopharyngeal duct, forming the ACP type. Histologically, since we know that the ACP type embryological origin is that of the primitive mouth, we can understand that histologically ACP type consists of reticular epithelial cells, and this is reminiscent of the enamel pulp of developing teeth. So if we look at the picture on the left, we see it is a low magnification of developing tooth bud. And on the right, we can see a high magnification of developing tooth bud where the star, the colored end star, is a stellate reticulum. The arrow here shows the odontoblast, which is the outer enamel epithelium. The open star here is the pulp, and the little triangle is the inner enamel epithelium, which is the ameloblast. ACP type have solid and cystic parts. The solid parts is the dense nodules and trabecular squamous epithelium, bordered by a palisade of columnar epithelium known as the picket fence. And we can see that's on the top right picture. The nest of squamous epithelium is surrounded by loose aggregates of squamous epithelium known as the stellate reticulum. And this is star-shaped basically, so hence its namesake. The cystic part is yellow-brown cholesterol fluid creating a so-called machinery oil. And you can see this down here on the right, bottom right. There are also nodules of wet keratin, which are desquamated cells forming large, pale eosinophilic masses with calcium. The second type, the papillary type, is primarily seen in adults and is related to the metastatic theory of development. So for some context and background, based on the PCP type, you have the MAPK-ERK, which is responsible for regulation of cellular proliferation, migration, differentiation, cellular growth, and apoptosis. Together with other genes like BMK, GNK, and P2D8, this pathway can be abnormally activated, like the ACP pathway. But the pathway more transmits signals to RAS and RAF, and that would cause the uncontrolled proliferation, the altered apoptosis, enhanced migration, all events essential for tumor growth and formation, as we know. So in this type, though, this pathway can be activated via mutations in the BRAF gene or by interleukins, as in the ACP type also. But the BRAF gene mutation is present more in the PCP type by 90%. So the mutation in BRAF is related with persistent activation of the MAPK-ERK pathway. Embryologically, the PCP type occurs when the adenohypophyseal cells of the pars tuberalis undergo metaplasia, resulting in squamous cell nests, which proliferate. They are well circumscribed compared to ACP type and less commonly invade brain tissue. So like complete surgical resection can actually be obtained in these types. PCP type shows cauliflower-like morphology on histology, with solid sheets of well-differentiated non-keratinized and squamous epithelium around fibroblasculous cores. And you can see that here. Clinical manifestations. So as the tumor grows, it causes the optic chiasm to be compressed, and that leads to bilateral hemianopia, which results in headaches. Furthermore, the growth failure in kids can occur due to a deficiency of growth hormones, central diabetes insipidus due to decreased ADH secretion, and decreased gonadotropins or secondary hypothyroidism due to decreased TSH or secondary hypocortisolism due to decreased adrenocorticotropic hormone. There are syndromes which can occur as a result of the tumor compression and location. So if the tumor is in the prechiasmal/chiasmal area, it will compress the optic apparatus and we can get optic atrophy with the bitemporal vision loss. If the tumor is retrochiasmal, it can cause third ventricle obstruction, which results in hydrocephalus and thus the increased intracranial pressure, leading to papilledema and horizontal diplopia. But if the tumor is intracellular, we'll get compression of the pituitary stalk and the hypothalamic region, resulting in endocrinopathy and headache. In terms of diagnosis, there's a battery of lab tests that we could see here on the left-hand side. But more importantly, we have basal prolactin, beta-ATG, and AFP, which should be done specifically to exclude a prolactinoma and secreting germ cell tumor. Visual field tests, visual acuity testing, as well as fundoscopy should be performed in kids, especially since optic atrophy and papilledema is associated with poorer visual outcomes. Optical coherence tomography, or OCT, is a good method to assess retinal nerve fiber thinning, more specifically for kids with severe degrees of visual acuity or visual loss. Routine imaging workup for craniopharyngiomas modality of choice is MRI. Where high three-dimensional spatial accuracy and tissue contrast definition are achieved by the combined use of 3D high-resolution axial, sagittal, and coronal T2-weighted images and volumetric T1-weighted sequences. CT can also be used, but it's more like as adjuvant in detection of calcifications. Use of the Puget grading system helps reduce chances of adipsia, hyperphagia, and obesity. And we can see the system here on the table. So if we look at it, and then we look at the images also, grade 0 shows no involvement, right? Grade 1, you have the hypothalamus being displaced by the tumor, and grade 2 has hypothalamic involvement. So looking at pre-op and post-op MRI now images, you can see grade 0, there's no damage to the hypothalamus. Grade 1, you're seeing minimal damage, and grade 2, severe hypothalamic damage. Excuse. So now in this roadmap, we can see that the early post-op MRI, that's within 48 to 72 hours, is used to assess presence and extent of the residual disease and any surgery-related complications. So during radiotherapy, imaging surveillance is warranted since cystic enlargement may occur and evacuation of cyst contents would be done. Follow-up imaging for tumor reoccurrence can be done via MRI every year for 5 years when there's no residual disease, meaning like complete resection. But if the tumor is partially resected, it should be done yearly for 10 years. On imaging for ACP type, CT, ACP type shows the cysts that are large and dominant with 90% enhancement of solid components and the calcification peripherally located. The MRI shows cysts on T1 that we could see that are iso-hyperintense compared to brain and hyperintense on T2 with solid components on T1 contrast on GAD showing vivid enhancement. The papillary type shows on CT cysts that are small and not significant with soft tissue density and vivid enhancement of the solid component. On MRI, we see T1 hypointense cysts, slightly hypointense to brain solid component, and vivid enhancement on T1 with contrast. Concerning management, a multidisciplinary team of specialists should be applied. This would include age-appropriate neurosurgeon, radiation oncology, endocrinology, and neuropathology. And according to the national UK guidelines for the management of pediatric craniopharyngiomas, surgery with a complete or subtotal resection or cyst aspiration should be considered since it has better overall and progression-free survival compared with conservative management alone. So also, when there is clear evidence of hypothalamic involvement on grading, no surgery should be done by a complete resection. So now on a more practical forte, we should be asking ourselves, well, why surgery? What's the role of surgery? Well, we have a Kaplan-Meier survival curve here on the left, where we could see CR being the complete resection and IR being incomplete resection. And we can see the progression-free survival is about the same for 20 years for both groups, with losses incurred after this, right? But this is essentially important because it also includes adjuvant therapy. And essentially, this can show a maximum safe resection up here by 1.0 versus need for oncological resection. So maximum safe resection can be done via craniotomy, but it could also be done via endoscopic endonasal routes. Cysts can be treated via drainage versus Ommaya reservoir. And since many patients develop hydrocephalus, it can also be treated primarily by shunt placement. The two main surgical attitudes are radical surgical excision and intentional incomplete. So for example, let's say there's pituitary involvement and the stalk has tumor cells. Tumor resection is the best choice. But if the stalk has no tumor cells, it's best to preserve it since this decreases endocrine dysfunction. However, in kids, this is different since their stalk has no role in recovering endocrine function. So total resection can't be done. Radical surgery has lower recurrence rates, whereas conservative has lower incidence of endocrine deficit, but runs the rare risk of post-radiation malignant transformation. So in terms of management, again, in terms of surgical management, there are several grading systems that have been developed based on location in order to decide on the best modality for surgery. But Chasm et al. System is based on the infundibulum and strategizes surgical approach, where we could see that type 1, a pre-infundibular, which are subchiasmatic tumors displacing the optic chiasm superiorly and posteriorly. Type 2, transinfundibular and extends into third ventricle. Type 3 are retroinfundibular and can either extend superiorly into the third ventricle or inferiorly into the pontine cisterns. And type 4, mainly located in the third ventricle and are best approached with craniotomy or transcortical approaches. So merging all that information into a more visual and practical approach now. These are all endonasal approaches. And of course, you could go endonasal transphenoidal. But then we have subfrontal, which has the advantage of getting to the suprasellar components straight on. And so this will decrease the amount of blind spots that you have compared to if you will go in infralateral. The intraventricular tumors, you can get anterior transcortical or inner hemispheric transcallosal. And of course, you're less likely to go through the posterior approach. So basically, solid tumors, endoscopic endonasal approach is best. The transphenoidal is the anterior midline approach, which is the most common. And they can get grade 1 and grade 2 tumors and have a decreased risk of visual injury, but can be difficult in kids and have CSF leakage. In terms of adjuvant therapy, there are 3 main types. There's radiotherapy, chemotherapy, and targeted/gene therapy. So UK guidelines states to offer deferral of adjuvant radiotherapy where the surgical impression of complete resection has been confirmed on post-operative imaging. It's been noticed that subtotal resection and radiotherapy is equivalent to the outcomes for gross total resection, but with lower morbidity. In terms of chemotherapy, this has a role in management of recurrences, either bleomycin or interferon alpha treatment into the cyst. So this is usually done though for like one dominant cyst. And for bleomycin, it usually takes a 3-week course to half the size of the cyst. And interferon alpha usually takes a 4-week course to get to half the size of the cyst. Then there's targeted/gene therapy, and this is primarily used for the papillary type, which, as we could recall from before, is the BRAF/MK signaling. So the effects of radiotherapy, they have been looked at over many years, over many studies. And this table here pretty much sums it up all. So we could see that across the board, subtotal resection plus radiation therapy is the same and or better than gross total resection alone or subtotal resection alone in terms of progression-free survival. So in terms of follow-up, according to the response assessment in pediatric neuro-oncology working group, the initial post-op MRI should be done within 2 weeks of surgical intervention. Furthermore, visual field test, pituitary function test should be done with patients having lifelong hypopituitarism follow-up and HRT within 1 year of surgery. Regarding differential diagnosis, Germ-Stack tumors are 3% of CNS tumors in kids and occur in the midline intracranial axis, which traverses the third ventricle. There are sometimes suprasellar tumors, which can infiltrate the floor of the third ventricle, pituitary stalk, pituitary gland, and optic pathways. Pure germinomas don't secrete. However, the non-germinomatous secrete AFP and beta-HCG. The clinical manifestations of these include hydrocephalus, headaches, fatigue, and blurry vision. And on MRI T1, they appear as hypo to iso intense versus on T2, where they are iso to hyperintense. They respond well to chemotherapy and can be treated using 3 courses of carboplatin etoposide chemotherapy, then 24-gray radiation. Okay, thank you, everyone. And these are the references.